want to change gear quite a lot and just look at how we think about asthma or managing asthma, because right now it's managed as an acute episodic disease, and what we've got is poorly controlled asthma, and we need to change the whole way we approach asthma management, and I think looking at it as a chronic disease and looking at chronic disease models is quite helpful. So the first thing I want to look at was this. There's a UK review of asthma deaths. So this was a 12-month period where they looked national, and they had 195 deaths over the year, and they looked at how the patients have been managed. So the first thing was that these were mostly adults, and so they were mostly moderate or severe. So mild patients they thought weren't dying of asthma. That's different in children. Children can have their first asthma attack and end up in ICU or dead, and children with mild asthma can end up in ICU or dead. But for adults, it's really about moderate and severe asthma, which means all of these patients should have been under regular review and should have been under active treatment. 43% of deaths had not seen their GP in the last 12 months.
So this is adults you're talking about now?
This is adults and children, but mostly adults. Quality of routine care, so day-to-day care, was inadequate in 62%, according to the people who did this review. Only 23% had action plans. So remember, we're talking about severe asthma. They should have all had action plans. And this is the group that really worries me and why I go on about ambulances. 45% died at home without seeking help. And when we had an epidemic in New Zealand in the late 80s of patients dying from asthma, they died at home without seeking help. 10% died within 28 days of a hospital visit. So that's a failure of the hospital system. Something should have happened then. 39% had more than monthly salbutamol prescriptions. So remember, in the UK, you can only get it 1 month at a time on your prescription. So if a GP is prescribing more than monthly, it should have raised an alarm bell. So that's a bit different to New Zealand, where you dish out 3 and 6 inhalers at a time. 30% had fewer than 4 of their inhaled steroid canisters per year. Okay, so 30% were taking less than a third of their drugs. 32%, so this is a hospital thing, 32% had avoidable factors in the management of their final attack. So this is patients taking more than an hour to get inhalers once they reached hospital. So the implications of this were, first, the most important was asthma patients need ongoing follow-up. They need to be reviewed regularly. And somehow we need to switch from you're acutely sick with your asthma, so you go to your GP, to you come back every 3 months to see your GP. I know it's possible. I know you've all got cervical screening programs. But at the moment we're not set up to do that. But we need to be, and I think PHOs, if anyone's involved in a PHO, you could take a lead in this and develop a system. Mandatory follow-up after hospital presentation, I think that's quite important, because the recommendation was people see their GP. But the problem we have in New Zealand is specialist services are discharging their asthma patients when they really need to keep seeing them.
And the other problem is that every discharge summary that comes to a GP says to the patient, you should see your GP. So
yeah. So a structured review of asthma at least annually. So this is something we do in cystic fibrosis. We sit down with the patient every year and we go through their growth, we go through their drugs, we go through all their exacerbations, we check their blood tests, we check their compliance, we check all their treatments. And it's the same model, that asthma needs to be reviewed properly every year, and it needs to include asthma education and an action plan and checking inhaler technique. Otherwise, 50% of people are dying from their asthma unnecessarily. So it's quite, in preparing this talk I went on the internet and trying to find how to do chronic care. It's quite difficult, but this is published in 2002, and they pretty much just said exactly the same thing I did about recall systems, and nothing's changed in the last 13 years in terms of developing these recall systems. But for patients to manage their own chronic care, patients need to be informed, so we need to do asthma education. They need to be motivated, so we need to do more than just tell people about their asthma, we need to get them enthused about it. They need to be prepared, so they have to have an action plan, and they have to have access to medications, which is a big problem in the US, where a lot of people are uninsured. And again, it requires extended and regular healthcare contact. So asthma patients need to be regularly coming back to see their GP or practice nurse. Barriers to self-management, lack of knowledge, education again. Poor perception of control. This is a really difficult one. You know, I was showing those slides before about a lot of patients with severe asthma not taking their inhaled corticosteroids. You know, a lot of people come into my clinic wheezy and short of breath but think they feel fine. They just don't realise that they're poorly controlled. And adherence to medication and cost of medication, which is less of an issue in New Zealand but it's a big issue in the States again. In order for someone to manage their disease, they need these skills. Problem solving, decision making. So they need to develop those skills. So they need to be educated and they need to be re-educated and develop these skills. Resource utilisation, they need to know what to do and when. We need a good relationship in terms of a good partnership in terms of developing that. And they need to know when and how to take action, which is again back to the action plan. So self-efficacy is an essential component of chronic care self-management, which means that when we educate patients about disease, we need to enhance their ability to do these things, to problem solve and make decisions. And the main thing is repeated education. If you think about, you go from a student to a skilled practitioner, it's because you've learned the same stuff over and over again in increasing complexity. And then you've gained experience doing it. And the patients need to do the same thing. We need to start with something basic and then we need to repeat the message and then repeat the message and repeat the message.
So sometimes that means including, you know, the referrals to people in the community who can go back and do some of that repetitive stuff because often you're dealing with stress, a lot of stress in one case.
Yeah. So tips for encouraging self-efficacy, small successes. You know, it's important to give, you know, have the patient manage something small and succeed, so then they can build on that and attempt something more difficult. So break down tasks into manageable chunks. Social modelling. You know, I had another patient who was like this and they did this and it worked really well. Positive coaching and motivational interview. So, you know, not just telling people about the disease, but encouraging them and getting them feel like they can do it, like you're the soccer coach and got a bunch of 4-year-olds you want to line up and kick the ball. So I've talked about the UK thing, but this is the similar sort of stuff from New Zealand. So this is a report, it's health literacy for Maori children, developed and it's published this year. A lot of this applies across the board, not just to Maori. And this report is reviewed in BPAC in May or June, so it's just been published as well. So whānau were interviewed about what their asthma management and what they've been taught, and they reported not having adequate knowledge. Less than 50% of families understood what asthma is. You know, so they're trying to manage a disease, they don't even know what it is. A third reported not knowing how to seek urgent help. So they hadn't been taught, and this is a life-threatening disease that could come on suddenly and kill their child, and they hadn't been taught what to do. Not being listened to, given too much information at once, so that chunking of information is really important, and they've been taught how to do something but not why. And I think that's that. You start with a basic message and then you add complexity so people understand why they're doing what they're doing, and then they can adapt it when circumstances change. Because if they don't know why they're doing something, they can't adapt at all to changing circumstances. Health literacy in New Zealand is poor. This is the world average, 0.5. And non-Maori are just below that, but Maori have much poorer health literacy, which is a big issue, and it's our issue. So in terms of educating patients about disease, we also need to be improving patients' general health literacy. And this is just a statement from that same report. So what is good asthma education? 1, it enhances health literacy generally, and 2, it enhances self-efficacy. And this is a strategy from that report. So first, deliver knowledge in an understandable way. So we want to avoid using too much medical jargon. This is all pretty basic stuff when you actually read it. And so it's a bit surprising it doesn't happen. Using effective strategies to communicate, and what they're referring to there is actually using different media. a bit of verbal, a bit of print, a bit of electronic, varying the strategies for the patient. Workforce development, building relationships and working together, so that's partnership with the families. But also, I'm going to be honest, no one ever taught me how to do health literacy education. So actually, that's something we need to develop, is we need to train people how to do that. And then develop models of care that meet health needs of Maori. Because, I've seen quite a lot, we put a lot of resources into Maori healthcare, but the people don't come. So we need to find what they want and give them a model of healthcare that they want and that works for them, rather than imposing a health model that suits us. And as I've said, education takes time and repeated effort. So that's another reason for reviewing patients regularly, is that on each occasion you can deliver some education. Deliver education in chunks, education at all visits, with specific recommendations at each visit. And I'll show that on the next slide. Incorporate a variety of media, build rapport by building partnership, and for yourself, get training in health literacy if you can find it. I don't know. And the goal overall is improved self-management. So, for adults, we want the patient to go away and look after their own disease eventually, after we've seen them multiple times, and they've become the expert in their disease. And likewise, we want the families of children with asthma to become experts in management of that disease. One of the problems we have is that every health professional uses different language. So it's important we actually have a shared language and we're all using the same words. So recommendations is to use the word puffers rather than inhalers, relievers and preventers, and use the word flare-ups instead of exacerbations. And so we all start talking in the same way, so that no matter who you see, you hear the message in the same way. Patient education. So this is a plan for visit 1 and then visit 2. So you start with pathophysiology. You remember the small airway with the inflammation and the swelling, the treatment, relievers and preventers, and how to use the inhaler. Get the patient to demonstrate it. And then the action plan, recognising worst symptoms and what to do. And so I took this from an article where they recommended doing this on the 2nd visit. So usually when patients come to see me, they're on to their 50th visit, so it's easy for me to do it all in one go. If you Google chronic care management, you get this list of requirements, none of which actually seems to have anything to do with treating a patient in front of you. But if you look through this, all this will resonate with what you hear this afternoon. And what it boils down to is having data. Data for the patient to manage their own disease. So that's where the asthma control test comes in, that's where the patient doing peak flow comes in, but also data for you to manage the patient, but also data for you to know how all your patients are doing and to manage all your patients and see what you're doing. Data, and data for the system. Data. Okay, so that's what all that's about, and you'll hopefully hear more about that this afternoon. So in summary, children with asthma just require regular review, and somehow we need to develop recall systems that enable that. At every review, so every time I see an asthma patient, I check their asthma control. So if I see someone I don't see people with cervical smears, but if I saw someone with asthma for a cervical smear, I'd check their asthma control. And you can give them an asthma control test in the waiting room if you want. Check their adherence every single time. Every time I see them for asthma, or if I have to increase their inhaled corticosteroids, in children reconsider the diagnosis. In adults, hopefully you've done lung function testing. Check symptom control, check inhaler technique, which means getting the patient to demonstrate their inhaler technique. And I have patients that I have to reteach them every 3 months. And it makes me really mad because I am the 8th doctor to see them and they still don't know how to use their inhaler. Preventive care, vaccination, smoke cessation, check growth. This is something I do because the patients are on lots of inhaled steroids. And education, including an action plan. Every time you see them for their asthma. Any questions?
So, I found it very interesting. Last year I was at a hospital twice with respiratory distress. In not one study given a acute management plan. Not one of the doctors knew what QVAR actually was, because it was so new out on the market. And I just found it really intriguing that when I asked some questions, they couldn't actually answer those questions for me.
No.
And the doctors and the nursing staff there. So I mean, I sort of think, what hope of people going again, going to the hospital and then back to the GP.
Yeah, I think I there's a massive cultural problem in hospitals too, in that we get the most junior member of the team who knows the least about what happened to the patient to discharge the patient, give them their prescription and their education. So that's something else we need to address. Yeah.
I said one point, it's only for a select group of patients, but we have specialist clinics at our practice, so the specialist actually comes out of the hospital into the community and sees our patients in the clinic. And what that kind of does, and also does case collaboration, so even if it's not the patient there, but talks about patients, and that can build the kind of education within the practice, within the professional, that means that plans are more coordinated, and patients are often more likely to attend at the practice than go to, like, DNA rates at the hospital and things like that. But that can be quite a, way of integrating care.
Yeah, no, that's fantastic. The weakness of it is it's very specialist dependent. Like your practice might have a respiratory specialist, the next specialist might have a diabetes specialist, and the vast majority of asthma patients from primary care. So I think this is really a PHO issue.
It's also about getting every level of the clinicians to the patient the same thing. That is, the nurse, the GP, the person they see at clinic, and that doesn't often happen. So it's all about us working together.
I think in the last Best Practice Journal there was an article about having an asthma champion in each practice. So maybe that champion could make sure that we are on the same facilities.
Especially in ED.
Yeah.